Good evening, everybody. I'd like to thank everybody for coming tonight to the first meeting of the Fort Worth Surgical Society for 2017. I want to welcome those tonight. We have some medical students, Stephen Atkinson, Jacob Wilson, others from UT Health Science Center. I want to welcome again Aaron Eves, who's our first year college student at Hill College. Dr. Dwayne and Dr. Fultz from JPS, welcome. Also want to welcome our remote sites. We have Dr. Covington, a new member out at Palo Pinto General Hospital. We have Dr. Tom Long and associates out at Decatur. So welcome everyone. This is a first for the Fort Worth Surgical Society. This is our first annual JPS Chief Resident Lecture. I want to thank our Moncrief partners, as we always do. We're in our third year. I'm reminded tonight of our partnership. Dr. Keith Argenbright cannot be with us tonight. Our two IT experts, Don and Jonathan, have been very helpful. And I'm going to tell you some things we accomplished after about a year's worth of work. I'm proud of tonight. So thanks for being great partners. This is your executive committee. There are 10 members. Dr. Dwayne is a new member. Dr. Sharif is a new member. We meet as often as we can. We do the best we can. I think we're still alive and getting stronger every year. This is our lecture schedule for the remainder of 2017. We're already filling up the fall lectures in 2017-2018 season. Next month is complications of bariatric surgery, diagnosis and management. We have our first, in a while, our first drug company speaker on wound care. I'm going to look into that a little bit more. Breast reconstruction coming up, and then a vascular surgery update. Dr. Joseph Mills, that should be M-I-L-L-S, from Baylor College of Medicine in Houston, is going to talk to us about what's happening in vascular surgery. Where is the pendulum? Is it gone too far with the endovascular? Should be very interesting and very provocative. So that's our schedule for 2016 and 17. These are the new rules actually for how we will get CME credit to everybody, and this is be helpful too for those at our remote sites. Candace, Dr. Long, all the folks down in Crockett, and our newer remote site partners. Two ways to sign up for your CME credit for UT Southwestern: by cell phone call. This is your event number 348-204, by internet browser. And we are working on, and I'm going to enlist Dr. Dwayne's help down the road to getting MOC credit for everybody. So right now, these are the new rules for getting your CME credit. There are handouts outside that Justin provided for us. This handout here is a couple of pages, describes really step-by-step how to do this. So we really want everybody to take advantage of these lectures and get a CME credit. I will show you in a few slides that we're now able to embed our lectures on the website. And everybody will be able to look at them. We'll be able to see who's tapped into the website and make sure they get CME credit as well, watching these at another time. A bit of news. I want to say happy retirement to one of our members tonight, Dr. Brett West, retired. I'm glad to see him with us tonight. Just a few quick rules about etiquette with video conferencing. We learned these by I guess on-the-job training last year. We had one of our sites who's not with us tonight at Graham. Their dog came in the room and started licking water from their bowl during the video conference. That makes a loud noise, and so don't have your dog in the room. Don't be eating when you're on the video conference, and don't video conference in the bathroom. There are a couple other rules here. This was a article from the Wall Street Journal about the etiquette for video conferencing. One of our new initiatives just sort of fell into our lap. We'll see where this goes, but a number of us went to a sporting clay event with the Fort Worth District Dental Society in October. We had a lot of fun. They wanted to somehow work with us to have some get together and have some social events. They're putting together a golf day in April, what they call a shred-a-thon day, which is very popular, and they want to repeat their sporting clay shoot and have us go in with them on the sporting clay shoot in the fall. So we're kind of exploring right now, doing some social events with the Fort Worth Dental Society. As we discussed with them, they have the same challenges we do about getting younger members to join and to attend. I'm really quite excited about this. The top picture is the first page, the home page of our Fort Worth Surgical Society website. It doesn't show it very well, but you can see our first two lectures are here. So if you click on the November lecture by Suhail Sharif about gastric carcinoma and lymph node harvest, all you have to do is click the arrow. Here's this picture right here. You can hear the entire 45-minute lecture, the Q&A session afterwards, and we're working on, actually if you call in, you should be able to get CME credit for this. We're able to record and embed our December lecture with Dr. Noel Cloven on the morcellation controversy. Our next phase is going to be to decide where subsequent lectures go, probably on the member services page, with be protected with a user ID and password. So we're now able to record these lectures, and we are recording right now as we speak. Just last weekend, I was contacted by Dr. Yerbati, and he wants to talk to us about a relationship with the residency over at Plaza, with somehow working their grand rounds into a cooperative grand rounds with us. It was very early, of course, in the exploratory phase, but what this will do will make mandatory requirement for attendance with their residents and staff, so we're exploring that new relationship. A few CME activities that are out there. I don't want to prolong this, but there's a MACRA talk at Harris downtown here January 18th. MACRA is going to affect all of you young surgeons. It's the new paradigm of value-based medicine. You need to start playing this game. There's a Harvard course on internal medicine for surgeons and specialists in January. Peripheral vascular update down in San Antonio coming up. This is an interesting third part in the series. This talk at UNT Health Science Center on Saturday, February 11th, is put on by the Tarrant County Medical Society Ethics Consortium. This is about the second of the three-part series, basically on the healthcare, improving the healthcare in populations. Here's a digestive disease surgery week course coming up, Heart Symposium at Harris, and as you know, the ACS North chapter and South Texas chapter are going to be meeting together in a combined meeting in Austin, February 23rd through 25th. Some more CME. There's a hernia course at March in Cancun. The annual Harris Trauma Symposium is Thursday, April 6th, coming up. A colorectal course in June in Seattle. Matt, as I mentioned, Matt Foltz is our first, hopefully annual, JPS Chief Resident Lecturer. Matt got his BA degree or Bachelor of Science degree at the University of Oklahoma in Norman, and stayed and got his medical degree there May 2012. He's finishing up his general surgery residency at the Baylor Scott and White University Medical Center, Dallas. It used to be called Bumsey, now it's Bezwumsey. Baylor Scott and White, Bezwumsey in Dallas. Anyway, Matt is going to talk to us tonight about what's new in the treatment of thyroid nodules, both the diagnosis and treatment. Matt has accepted a trauma and critical care fellowship. Is that 2 years or 1 year? Just 1 year at Washington University in St. Louis, and he's excited about going to St. Louis. So without further ado, I'm going to turn the podium over to Dr. Foltz, who will talk to us tonight about the treatment of thyroid nodules, what's new in 2017.
Okay. Alrighty. Thank you, Dr. Crawford, for inviting me, and Dr. Duane for setting this up. My name is Matt Foltz. I'm one of the chief residents at Baylor and here at JPS. Like you said, I'm going into trauma critical care. So you may ask, what's somebody going into trauma, why they've been interested in thyroid nodules? Well, I was trying to think of a topic that'd be relevant to the general surgery community. And so I thought about cases that I would miss as a trauma surgeon, and thyroidectomies are actually my favorite case to do in residency. And it was a hard decision to make when I went into trauma critical care to give up head and neck surgery. But I relish the opportunity to talk about it tonight. So thanks again for inviting me. So what I want to talk about tonight is the objectives for the evening are to become familiar with changes to the American Thyroid Association guidelines, which have underwent a pretty significant change in 2015, and how these apply, how you can apply these to your clinical practice. I also want to talk about the Bethesda cytopathology reporting system, I also want to talk a little bit about molecular testing and briefly discuss indications for thyroidectomy. This is going to be a talk that focuses more on thyroid nodules, less on thyroid cancer. We will talk a little bit about the management of differentiated thyroid cancer, but the topic of how to manage thyroid nodules is going to be something that the general surgeon deals with on a fairly regular basis, and the recommendations have changed quite a bit since the ATA guidelines came out in 2007. So why are thyroid nodules important? So the incidence of thyroid nodules has tripled since 1975, between 1975 and 2009. It's estimated that approximately 50% of those age 60 will have at least one thyroid nodule. And within palpable thyroid nodules, cancer can be found in roughly 7 to 15% of these palpable thyroid nodules. And this is a graph that illustrates the increasing incidence since 1975, and the incidence has tripled according to the SEER data from 2012. Interesting to note that the overall 5-year survival has also increased significantly, and some of this might be to the fact that we're just seeing more thyroids with more thyroid ultrasounds being performed in the United States in both sexes, in all races. So before 2006, the management of thyroid nodules and indications for thyroidectomies were very institution specific. There was no consensus on when to operate, when to FNA. And seeing a need, the American Thyroid Association has been around for a long time, since 1923. In 2006, they released a consensus statement with approximately 80 recommendations of varying strength. These have since been updated since 2009, and again, and a big update in 2015, which added approximately 20 to 25 new recommendations. And under its current iteration, the guidelines contain 101 basic recommendations. Of these, only 11 are based on high quality evidence, but 40 plus are strong recommendations from the Thyroid Association, and we'll talk about that. And if you look through it, it's 133 pages long. It's long, it contains a lot of stuff, and so what I'm going to attempt to do in this talk is pick out what's important for the general surgeon to know and how these recommendations are going to affect their clinical practice. And so I talked about a little bit about strong recommendations, weak recommendations. The American Thyroid Association borrowed this system heavily from the CHEST guidelines, which had been producing recommendations for quite some time. And you'll hear me talk about strong recommendations. And what a strong recommendation is from the association is something that you can apply to most patients in most circumstances without reservation. And that's a strong recommendation based on either high quality, moderate quality, or low quality evidence. High quality evidence they would consider randomized controlled trials, whereas with overwhelming evidence from observational studies, without important limitations or overwhelming evidence from observational studies. Moderate quality would consist of more randomized controlled trials, but with a lot more observational studies intermixed, and low quality evidence is mostly from observational studies or case studies. Now, weak recommendation is action can differ. You can choose to follow this or not, and it's not necessarily the wrong thing to do clinically, but there may be other alternatives that would be equally as preferable in those circumstances. So this is kind of a breakdown of how the recommendations are, how strong the recommendations were. And as you can see, most of the recommendations regarding thyroid nodules, which is here in the white, are in the strong to moderate category, and very, very few of the recommendations are strong recommendations based on high quality evidence, but we will talk about those in this presentation. Oops. So let me go back. What I'll take you through is, this is the algorithm for evaluating and treating a thyroid nodule based on the ATA recommendations, and we'll refer to this slide first. So at this point, we've got a thyroid nodule, or a suspected thyroid nodule, and a patient that's referred to us, so where do we go from there? The first step, according to the guidelines, are to check a TSH. This is a strong recommendation, but only based on moderate evidence. In the setting of a high or high normal TSH in the thyroid nodule, this is associated with an increased risk of malignancy, and the management should be to get an ultrasound, which is probably what most people do anyway. If in this setting, if there is a low TSH, they'll probably get a thyroid scan, and in somebody with a low suspicion for a thyroid malignancy, which we'll talk about, these patients may get a radionucleotide thyroid scan. We're worried about malignancy in this talk, so we're going to ignore the patients with low TSH. So the next step in evaluation would be an ultrasound, which is a very useful tool, and we're getting more and more of those, performing more and more of these every year, and we're getting better at doing them. And thyroid ultrasound has gotten very good at looking at the thyroid parenchyma, whether or not it's homogeneous or heterogeneous, where they evaluate size, the number, size, location, and more importantly, the sonographic character of thyroid nodules, which we'll talk about. Additionally, every thyroid ultrasound that is performed should evaluate for cervical lymphadenopathy as well. The nodule characteristics we care about are whether or not they're solid, cystic, or spongiform. We want to know about the echogenicity of the thyroid nodules, and importantly, whether or not they have calcification in the shape and vascularity. All of these can be seen very readily on ultrasound. This is important and new since 2009, are the sonographic risk patterns, and this is how the guidelines suggest the thyroid results be reported. Because if you follow these risk patterns, you can base the risk of malignancy contained within that thyroid nodule based on a pretty large amount of data. So the sonographic risk factor categories are high suspicion, intermediate suspicious, low suspicious, very low, and benign. The emphasis in the 2015 guidelines are far more based on these risk patterns as they are in size. When I first started my residency, everything, and this was institutional, everything was based on size at our institution. And size is still important under these guidelines, but the sonographic risk factors become much more important. And we'll talk about why. This is the risk patterns as they appear in the guidelines, and this is kind of an overview of their estimated risk of malignancy, what the ultrasound features actually mean, what a highly suspicious nodule would look like, and what to do with them. And we'll talk about these more in detail in the next few slides. So a patient with an FNA with high-risk features would include nodules with microcalcifications that have hypoechoic irregular margins like you see here, hypoechoic nodules that are taller than they are wide, and nodules with irregular margins, and these are all good examples of these. This is a very good example of microcalcifications contained within a thyroid nodule. And these nodules be concerning for harboring malignancy, and nodules with a highly suspicious classification carry a 70 to 90% malignancy risk. And according to the guidelines, FNA should be performed on these nodules that are greater than 1 centimeter in size. This is a strong recommendation based on high quality evidence. This is a departure from the previous guidelines, because the previous guidelines suggest that anything greater than 5 millimeters should be biopsied. So this is probably one of the biggest changes that came with the 2015 guidelines. And that comes from a lot of data that suggests that even patients with micropapillary thyroid cancers that are less than 1 centimeter are going to do very well in 5 years, regardless of whether or not they're excised. The next risk pattern is the intermediate risk thyroid nodules, and these are ones that are more hypoechoic. They're solid with regular margins and do not contain microcalcifications. Anything with microcalcifications would be considered high risk. And these carry about a 10 to 20% chance of harboring a malignancy. The recommendations for these are the same as the high suspicion nodules, and anything over 1 centimeter, it is recommended that they you perform an FNA. This is a strong recommendation, but based on lower quality evidence. The next set is the low suspicious nodules. These harbor a 5 to 10% malignancy, and these are nodules that are more hyperechoic. They can be partially solid or partially cystic. They carry about a 5 to 10% chance of harboring malignancy, and these, the recommendation is that these at 1.5 centimeters should be biopsied. And this is not hard and fast. It's a weak recommendation based on low quality evidence. And you should remember that these are guidelines. There's a staff that at JPS that says guidelines are not guidelines, and I think that's true. These are suggestions that aren't necessarily the way they think you should manage all patients in every clinical scenario. And we'll talk about how to differentiate patients a little bit later with molecular testing. The very low suspicious lesions are lesions that are more spongiform, partially cystic, but have no suspicious features. These carry about a 3% or less than 3% chance of harboring malignancy. The recommendation at these at 2 centimeters should be FNA'd. This is a weak recommendation, but based on a little bit stronger evidence. And then things that fall into the benign category are things that like cystic nodules that carry less than 1% risk of harboring malignancy. And these should not be FNA'd. And the recommendation is that nodules that do not meet the previous criteria should not be FNA'd. Anything that's purely cystic or anything less than 1 centimeter. As I mentioned earlier, this is a departure from the previous recommendations. So what do we do about those nodules that we decide not to FNA based on these criteria? Well, they provide guidelines for these, and things that are highly suspicious but are less than 1 centimeter, they recommend a repeat ultrasound in 6 to 12 months. If they're less than 5 millimeters, you can wait up to 2 years or greater, but they do need to be surveilled in some fashion, preferably with an ultrasound and a physical exam. The low to intermediate suspicious lesions, you can wait to 12 to 24 months, and pure cystic lesions don't need follow-up at all, according to the ATA recommendations. So we have ultrasounded, we have a risk pattern, and we've decided to perform an FNA. Now, how are the FNA results going to affect our management? That's what we're going to talk about next. So the Bethesda system for reporting thyroid cytopathology was developed in 2007. It's a 6-tier system, and the ATA recommends that all FNAs be reported using the Bethesda system. And this is a strong recommendation based on moderate quality evidence. And I remember Baylor University in Dallas, which is a big tertiary referral center and a high volume center for doing thyroid surgery, the pathologists were not using the Bethesda system when I started residency. And it's only been over the last 3 years that they've really started using it. I remember the first thyroidectomy I did as a junior resident was for I think a little bit over 3.5 centimeter thyroid nodule, and it had not been FNA'd. But the practice, the system practice at that time was that anything greater than 3 centimeters needed at least a lobe. And that's what we were doing up until probably about 2014. So the Bethesda system for reporting thyroid cytopathology, like I said, it's a 6-tier system. And you can predict the risk of malignancy based on these FNAs using these criteria. Going from most malignant to least malignant is the malignant lesions. The follicular neoplasms are suspicious for follicular neoplasms, and before that, suspicious for malignancy. And the most interesting category is the indeterminate cytology category, which can consist of atypia of undetermined significance or follicular lesion of undetermined significance. Then you can have benign lesions, and then you can have non-diagnostic or unsatisfactory FNAs, which we see quite frequently. And all of these have the Thyroid Association has addressed in their recommendations. So starting with a non-diagnostic FNA, all comers, these can harbor, there's about a 1 to 4% chance of these harboring a malignancy. The recommendation currently is to repeat the FNA under ultrasound guidance. Ideally with on-site cytopathology, and that's not always possible. And this is a strong recommendation based on moderate quality evidence. Repeatedly non-diagnostic nodules require close observation or surgical excision. The practice at Baylor is usually surgical excision for these that have repeatedly non-diagnostic nodules. And this is, again, a weak recommendation based on very low quality evidence. And then they also recommend considering surgical excision with nodules with suspicious sonographic features, growth more than 20%, or there are other clinical risk factors like a positive family history or history of radiation. The more interesting class of FNA reports that you can have are the atypia of undetermined significance and the follicular lesion of undetermined significance. And AUS there's about a 5 to 15% risk of malignancy, and for the FLUS about a 15 to 30% risk of malignancy, which is interesting because that actually is about the same risk as follicular lesions on an FNA. And so we'll talk a little bit about that. So if a repeat, with an indeterminate cytology, the recommendations vary a little bit, and it depends on a lot of clinical factors. But you can, depending on what their ultrasound looks like, what their molecular markers look like, which we'll talk about a little bit later, and you can choose to observe these patients. A repeat FNA and or molecular testing is recommended, and this is a weak recommendation based on moderate quality evidence. About 10 to 30% of these lesions you'll have the same diagnosis with your FNA. And the recommendation is surgical excision if repeat FNA and testing is inconclusive or not possible, which is a strong recommendation that they feel most clinicians should follow, but it's not based on high quality evidence. A follicular neoplasm FNA carries about a 15 to 30% risk of the patient having malignancy. And historically, this has been surgery has been recommended, and it's still a strong recommendation, but there isn't a breadth of data out there to support this as a strong recommendation. And this is where things get kind of interesting, where you can start considering things like molecular testing. Again, this is a weak recommendation, but it's based on moderate quality evidence, and I think in the next iteration of the guidelines, as we see more data more long-term data come out with different molecular tests, and we get tests with more specificity and sensitivity, you will see this become a strong recommendation. Now, in order to rule out a malignancy, you'll need a test with a high sensitivity and a negative predictive value, which we just don't have yet. So I've talked a lot about this so far. Molecular testing, what we have now, it can be predictive, it can be diagnostic, and it can be prognostic. However, there's currently no one test that can definitively rule in or rule out a malignancy. And like I said before, we're lacking in a lot of long-term data with regards to molecular testing for these FNAs. So we do know that there are certain molecular mutations that can be prognostic as well as diagnostic for patients with suspicious lesions, and including the BRAF mutation, the RAS mutations, and the RET proto-oncogenes. And so the first test that was developed was the MIR-informed thyroid panel, which is a mutational analysis, and it looks at all of these. It looks at all the high-risk mutations, the BRAF mutation, and there's been a lot more data about the V600E mutation, KRAS, and whatnot. And these are more useful when you have a lesion that you have a higher suspicion for malignancy. This is a more prognostic test, and so if you've got a indeterminate nodule, it's not necessarily helpful because it doesn't have a really high negative predictive value or positive predictive value. It does it has a pretty decent negative predictive value, but not positive predictive value for these indeterminate nodules. And nodules that are suspicious for malignant cells, you can see the negative predictive value is very low, which makes it not a very good screening test. A newer test that's been developed is a specialized cytopathology test that actually looks at the gene expression of the thyroid nodule, the DNA in the thyroid nodules. And it was developed to identify benign nodules rather than malignant nodules. So it was developed as a test with a high sensitivity and negative predictive value. It does have a low positive predictive value. So that means that positive tests may represent benign disease. recently, it's added panels for FNAs that are suspicious. So if you get a gene classification that is suspicious, you can add on the mutational analysis that the MIR Inform had. It's a smaller panel, but it can add a little bit of positive predictive value for the test. This is just kind of a algorithm for what you would want to do. You have a thyroid cytopathology that's suspicious, or you just don't know what to do with, and you send it for molecular testing. It comes back as suspicious, so you can't rule it out, and you want to rule it in. They recommend doing the mutational analysis on this through Afirma. Most of the data from Afirma is coming out of Mayo. The UPMC has been a big proponent of ThyroSeq. And ThyroSeq, it looks at over 100 or over 1,000 hotspots of 14 different thyroid cancer-related genes, and 42 types of 42 types of gene fusions. It looks at the DNA and RNA from the FNA sample. So it's kind of a combination of a mutational analysis and a gene expression classifier. And it has a higher sensitivity and specificity than Afirma does. And so it's more of a rule-in test. And the results are promising from studies based on these. We can tell that the risk of having cancer with a negative ThyroSeq test with the indeterminate nodules is about 3%. And a follicular neoplasm about 4%. However, patients with a suspicious lesion, it's about 20%. So it's not perfect. The other thing that should be noted about these molecular tests is that they're very expensive. And we don't know exactly, we don't have the long-term data to suggest how these can help in our management of these nodules. So that's why at this point, getting these molecular tests is a weak recommendation, and can really they just recommend it serve as an adjunct in clinical decision making. The indications for ThyroSeq are your indeterminate nodules and nodules with follicular neoplasms. And then ThyroSeq can also be used to guide the extent of surgery in something that's malignant. So if you have a medium-sized nodule and you're not sure whether to do a lobectomy or a total thyroidectomy, the ThyroSeq testing can be useful. Or you have a nodule where you have repeated benign FNAs, but you've got like a very highly suspicious nodule on ultrasound. It can also be helpful when molecular profiling of a known cancer affects clinical decision making. Like if you are deciding whether to do ablation therapy, this might be a nodule that you would consider doing a lobectomy, but the hotspots are concerning on the ThyroSeq test. That might be somebody that you consider actually doing a lobectomy so they can get ablative therapy postoperatively. One thing we haven't talked about yet is what to do when we have a malignant FNA, which hasn't changed. The surgery is generally recommended, and it's a strong recommendation based on modern evidence. However, what's new is there is a recommendation, it's recommendation number 12, is that some of these patients with malignant FNAs may be observed. And these are patients with low-risk tumors like micropapillary cancers, 1 centimeter or less, patients that are poor surgical candidates or that have a short life expectancy, or patients that just have bigger fish to fry if they had an MI 3 weeks ago and you want to get them over their MRI. These are lesions that can be observed in the right circumstance, which is, it's a place for clinicians, they wanted to give a place for clinicians to hedge in these kinds of circumstances. Something that is new as well, so we've decided to operate, we have an FNA showing a malignant lesion, and they have a multinodular goiter, and you're wondering whether or not they have bulky disease. Previously, it was not recommended that the patients receive a contrasted next study, and that has changed, and they are now recommending patients with suspected bulky disease to get either a CT or an MRI with contrast, and this is a strong recommendation based on low quality evidence. Getting a PET CT hasn't changed in the new iteration of the guidelines. It's still not recommended for patients to undergo PET CT scans. And so how extensive should we be with our surgery? Now this has changed a little bit. So the recommendation now is for a total thyroidectomy in patients with nodules greater than 4 centimeters, or they have extrathyroidal extension or positive lymph nodes or distant metastasis. In those intermediate sized nodules, you can consider a thyroid lobectomy or total thyroidectomy, which is a new recommendation and I think misunderstood. Now, there is strong evidence to suggest in nodules of this size, regardless of the FNA results, if surgery is indicated, that these patients with less than a 4 centimeter nodule would do fine with a lobectomy only. However, in patients with high risk features, like concerning ultrasounds, or you've done molecular testing and they've are high-risk patients and they're high risk for recurrence, and the oncologist is going to want to give them radioactive iodine, then they leave room for doing a thyroidectomy, a total thyroidectomy in these instances. And in those cases where you do end up, now according to the guidelines, you shouldn't be, it's not recommended that you FNA nodules less than 1 centimeter, but it still does happen. And some patients can't stand the thought of having any cancer anywhere in their body, and they request a surgery for a nodule that's less than 1 centimeter. The recommendation is for just a lobectomy in those patients with clinically negative nodes. A note on central neck dissection: the recommendations have changed a little bit, and currently the recommendation is that it should be performed for clinically evident nodal disease, which hasn't changed, and you should do a prophylactic central node dissection for tumors that are T3 or T4 lesions in patients with papillary thyroid cancer, or there's lateral nodal involvement. And a quick word about RAI ablation, because this has changed as well. The recommendation is patients with low recurrence risk, there's no ablation, they do not recommend ablation. You can consider ablation for patients with intermediate risks of recurrence, and they do recommend RAI for high risk. But what has changed is patients that have, they recommend lower dosing for remnant ablation, but higher dosing for adjuvant therapy, which is a new recommendation this year. And so those patients that we've FNA'd but we've decided to operate on, the whole goal of the recommendations was to decrease the amount of FNAs that we perform and to decrease the amount of total thyroidectomies that are performed. And so if we're going to operate less on patients that we FNA, they wanted to have some good guidelines to follow in terms of surveillance. And currently the recommendation is there. Patients with highly suspicious ultrasound patterns, the recommendation is for a repeat FNA and ultrasound within 12 months. Low to intermediate suspicion, you get a repeat ultrasound in 12 to 24 months, or repeat ultrasound for growth or development of a new sonographic finding. And patients with very low suspicious nodules, the recommendation is to repeat an ultrasound after 2 years, if at all. The last recommendation is if a nodule has a second benign FNA, no further follow-up is needed. A quick word about TSH suppression therapy, because this has changed a little bit too. Routine TSH suppression therapy for benign thyroid nodules in patients with multinodular goiter, for instance, is not recommended. Though modest responses to the therapy can be detected, they determine that the harm outweighs the risk. And this is one of the few strong recommendations based on high-quality evidence. So this is a kind of a summary of comparison between the 2009 recommendations and the 2015 recommendations, and this was made by a really smart endocrinologist at Colorado named Dr. Hagen. And we talked about almost all of them from start to finish. The ones we didn't talk about were the last two, based on they're talking about adjuvant therapy, which most of us aren't going to be a part of, and that's for people that are smarter than I am to talk about, I think. So we talked about what to do when we have a nodule. We've gone from start to finish, from FNAs to surgery. So I want to give a couple of case examples that kind of highlight some of the big changes in the 2015 recommendations. First one was a healthy 48-year-old male with an 8 millimeter incidental thyroid nodule. It's hypoechoic, it has irregular borders and microcalcifications, but there's no abnormal lymphadenopathy on ultrasound. So this would be a very highly suspicious nodule. Patient has a normal TSH. So what will we do with this patient? They go to surgery, check a calcitonin. Do you FNA these people? Do you just survey them? And this has changed, and this is the patient. If you follow the guidelines, this patient would actually just get surveillance with a repeat ultrasound in 6 to 12 months. Next patient's a 38-year-old female with a 3.8 centimeter nodule. It's very similar to the first case that I did. They have a highly suspicious pattern on ultrasound, no abnormal lymphadenopathy. Based on the guidelines, they meet criteria for an FNA, and the FNA was consistent with a papillary thyroid cancer. So this patient would be somebody that, under the guidelines, would be a good candidate for a lobectomy without a central node dissection. However, prior to proceeding with that, it might be somebody that you consider getting molecular testing because they had that highly suspicious ultrasound pattern. Last patient is a 55-year-old female with a 1.5 centimeter thyroid nodule. They have a high TSH, a partially cystic nodule with eccentric and solid components. This is a low suspicious nodule. And they have an FNA with follicular lesion of uncertain specificity. And so really the question is what to do with this patient. And right now we don't have enough data. There's to give you strong recommendations either way. This is somebody that you could send for repeat FNA. This is somebody that you could get molecular testing on. This is somebody that you could consider just monitoring with serial ultrasounds based on the recommendations. So we still don't know everything. I think you're going to see several iterations of this in the near future. There's a lot of studies being done looking at this molecular testing, and I think you're going to see them refine the technology, and we're going to see a good test with a positive predictive value, a negative predictive value, and the recommendations are going to change accordingly. So that's it. Any questions?
Matt, good job.
Thanks.
Good job, very, very much. Thank you for that. Do we have any questions now from the audience? Can y'all hear us now, Tom? Out in Decatur, can you hear us? Okay. Dr. Covington, can you hear us out in Palo Pinto?
Yes, I can.
Great, okay. We're going to have Matt repeat the questions for you all. Are there any questions here in the audience for Dr. Fultz? We're going to put a slide up. I want to do a comment or two on the algorithm slide, the one that has the recommendations. This one here. Like Dr. Ziegler, I don't have a question. I just sort of have a comment from about 30 some odd years of practice. This is an interesting algorithm, but nowhere kind of on that. I make a plea to include the patient with the algorithm.
Absolutely.
Okay. It's well known that the incidence of thyroid cancer is much more common in the extremes of age. Men, sex is important, more common in men, and the extremes of age. Men over age 60, for children under age 15. So keep the patient in mind. Also, make sure, find out the family history. Is there a family history of thyroid cancer, history of MEN syndromes, previous neck radiation, find out where people are from. Somebody may be a relative of somebody who was near Chernobyl or Japanese or whatnot. So keep the patient in the context of all this. My experience was that also that with an FNA you tend to get one shot. A lot of people just didn't like 4 or 5 passes, even though they may have some Novocaine. They didn't like having a lot of FNAs. Now, most people would do them, and I'm sure they are at JPS. Done in radiology with pathology right across the hallway. So if the specimen was non-diagnostic, you can keep them there and go back and do it again. Oftentimes they have 2 sets of 6 or 7 needle punctures. So they just didn't like FNAs. So in the follow-up, discussions, it would be, that always was a big factor. I found in talking to people that, wait a minute, and more, another ultrasound 6 months, another FNA, no, I'm not going to do that. So people just don't like FNAs. And another risk factor too is long-standing thyroiditis. Hashimoto's thyroiditis is another risk factor for metabolic thyroid cancer. So that should be in the risk factor.
Absolutely.
They're high-risk nodules, but also high-risk patient context.
Absolutely.
To be sure and meld those two together.
That's an excellent point.
Any other comments from the audience? Questions from the audience?
Are you doing molecular testing at BUMC?
We do. We have to send it out. We don't have it at BUMC. It's not on site. So we have to send it out. And it's very clinician dependent. Some people like Afirma, some people like ThyroSeq.
Dr. Covington or Dr. Long, do y'all have any questions from Palo Pinto or Decatur?
No.
I did not.
Okay. Well, we hope everybody enjoyed the talk. I certainly did. Matt, thank you very much for
Yeah,
joining
sure.
us.
Thanks for having me.
Great first lecture. And I hope this was good practice. Good luck with your
Oh, it was.
presentation.
It was certainly good
At the
board prep.
Swamsey. Thank you everybody for coming tonight. We'll take a short break for a quick business meeting of society members afterwards. Thank you very much for attending. Next month is Dr. Hossein Bagshai, a new member, who's going to be talking to us about where we are with bariatric surgery, what works, what's out of favor, what are the metabolic complications or consequences of bariatric surgery. A lot of our members have asked him to speak on diagnosis of surgical complications of bariatric surgery and their treatment. So tune in next month for complications and treatment of bariatric surgery. And we'll get you advance notices and flyers. Thank you very much for attending. Thanks, Tom. Thanks, Dr. Covington.